Hi, everyone. I'm Allison Kukla. I'm the Senior Manager for Programs and Partnerships here at the Foundation, and I'll be your moderator this afternoon for our webinar on Back to School. This webinar is sponsored by Neurelis for Back to School Month, and will focus on seizure rescue therapies and seizure action planning for schools, not just grade school, but beyond, and providing essential knowledge and guidance to parents, friends, and educators so we can have a safe back to school. We are so grateful to the speakers who are with us and all of you who are joining us today for this webinar and this very important topic. Whether you're a parent preparing your child for grade school or a person with epilepsy getting ready to go off to college, you're going to learn a lot from our experts today. During this webinar, our experts will provide education on the importance of seizure action plans, being prepared with seizure rescue therapies, and provide other tips to increase the chance you'll have a successful back to school season. So I'm pleased to have them with me, and I'm going to go through their introductions. We have Drs. Wendy Trueblood Miller, Dr. Corin Williams, Monique Hopgood-Willis, and Brittany Miller. And as a person living with epilepsy myself, I might chime in a few times to provide some lived experience comments as necessary. All of these panelists bring a different perspective and expertise to the conversation, which is very valuable. I'll first introduce you to them, and then we'll start the discussion. So first, I'll start with Dr. Miller. Dr. Miller is a registered nurse, clinical nurse specialist, and a professor and executive associate dean for research at Indiana University School of Nursing. She is also a person living with epilepsy. Dr. Miller has been engaged in leading quality of life, condition management, and access to care research in adults with epilepsy for more than 16 years. Welcome, Dr. Miller. We have Dr. Williams. He is the director of the epilepsy program at Barrow Neuroscience Institute at Phoenix Children's, which is designated as a level 4 center by the National Association of Epilepsy Centers. He obtained his medical and graduate degrees from Washington University in St. Louis and completed his clinical training in pediatrics, child neurology, and clinical neurophysiology at Baylor College of Medicine in Houston. He is board certified in child neurology, clinical neurophysiology, and epilepsy. We're excited to have you, Dr. Williams. Monique Hopgood-Willis is a fighter who refuses to let adversity define her. After surviving bacterial meningitis that resulted with epilepsy and cognitive impairments, she continues to live life to the fullest as a dedicated wife, loving mother, and passionate neuroscience graduate student. She is committed to helping others by educating in neurological diseases and helping people take charge of their health. Monique shares her medical knowledge and personal triumphs with warmth and wisdom by detailing her own story of thriving after adversity. Welcome to the panel, Monique. And last but not least, we have Brittany Miller, who's the executive director for Arizona and New Mexico here at the Epilepsy Foundation. She started her journey with parent and patient advocacy over 14 years ago when her youngest daughter, Brooke, was diagnosed with Aicardi syndrome, cerebral palsy, severe epilepsy, and many other medical diagnoses. Brittany joined the Family Advocacy Council at Phoenix Children's Hospital, where she has served for over 10 years. She currently serves on the Phoenix Children's Neurosciences Patient and Family Council and the Patient Safety Committee and the Patient Family Faculty. She is very involved, and we love to have a good patient advocate on the panel. So welcome, Brittany. So welcome to all of you, and I'm so thrilled to have you all here with me. And I do want to clarify, the webinar is here for education, and we are not here to provide specific medical advice. So please, when you're asking questions, use the Q&A box and keep your questions general in nature for our panel. And when we make sure to ask your questions to our panelists. So let's have some fun and start the discussion now about back to school success and ensuring safety for students with epilepsy. So I'll first start with Dr. Williams. As we've noted, it's that time of year when parents and students are getting ready to go back to school. Specifically, what should parents be thinking about to get their children prepared for back to school?
Well, Allison, first of all, thank you and to the Epilepsy Foundation for inviting me. I really enjoy being here and I love talking about fall. It's my favorite time of the year. It's always nice to get a break from the heat, and we know the holidays are right around the corner. So always my favorite time of the year. I think to your question, it's a fantastic question because I think it encapsulates a lot about epilepsy, particularly from the pediatric standpoint. I often tell families when I think about epilepsy, I think we all think about seizures, and I know we're going to speak a little bit more to this. I think top line, we want to talk about seizure action plans, sharing diagnosis with school professionals, particularly school nurses. I would say in my time here in Phoenix, I have seen an ever increasing awareness on the part of school health personnel about this to the point where they sometimes demand seizure action plans, even if parents don't proffer them or offer them. They demand the presence of rescue medications. And I can say, over the past decade and a half, that was not the case when I first arrived. So I think there's a greater awareness, at least in Phoenix, and I hope more nationally that's the case too. As I said, we're going to talk a little bit more about that, but having a written seizure action plan, having availability of seizure medication or seizure rescue medications is so important. But I also like to have families think a little bit more about some of the comorbidities of epilepsy that may or may not always be talked about. So we know that 20% of people with epilepsy do have underlying learning issues, and that's so important. We're talking about school-aged children. So I think families also need to be alert to that. I've certainly seen that can impact mental health significantly if there are unaddressed mental health issues that can lead to challenges with school performance and being able to even participate more fully in school. That also leads to one of the other important comorbidities of epilepsy. We know about 1 in 3 patients with epilepsy also have a diagnosable behavioral health condition. Particularly when we talk about the pediatric world, we're talking about things like ADHD, something that doesn't have a true diagnosis, but executive functioning skills, but even things like anxiety and depression. Again, those can significantly impact a child's performance in school and can also impact their control of their seizures. So I think it's important for parents to be aware of all of those things. They're interrelated. I can't always say one leads to the other. Sometimes it's a bi-directional sort of impact, but I think it's something parents should also be aware of. So I think that's kind of my top level view about what parents should be thinking about when they get back to school.
Well, thank you for that. Really wonderful information and lots to think about. But, having your healthcare team, I know personally to have those open and honest conversations with are so helpful when planning, back to school and all of those pieces. So thank you for all of that information. So, and I would love to transition to Brittany so we can get, a parent perspective after hearing from Dr. Williams. So Brittany, as a parent of someone with epilepsy, can you tell us a little bit about how you prepare for back to school? Just if that's, 504, IEP plans, or, just how do you prepare for back to school when, thinking about Brooke and working with your healthcare team?
Sure. Thanks, Allison. And thanks again for having me today. Back to school season evokes lots of feelings for parents across the country. We're excited, let's be honest, that our kids are going back to school. We're a little apprehensive. We hope their teachers will love them. But for a parent of a child with epilepsy and other disabilities comes fear, worrying about them, being cared for in the school to appropriately know how to address their seizures. Also, wanting the IEP team, as you mentioned, to see them as an individual and not have Brooke be defined by her epilepsy. So there's lots of feelings. So for me, every summer, I really make sure I have an appointment with her epileptologist, who is here with us, Dr. Williams. She has great care to go over, her seizure protocols for the year. So that way her seizure action plan is updated. I can share it with her school team. Thankfully, like he mentioned, in Arizona, the awareness and recognition for the need of seizure action plans has been a lot more active, especially since legislation passed a few years ago. But Brooke is almost 15, so early on in her journey, we didn't have that. So I myself, as a parent, would make it a point to, as soon as I found out who her teacher was, I would see if I could get an appointment on the calendar to meet with her, talk to the aide in the classroom, go over what her seizures look like. She has several types, and depending on the type there's a different response. And so just making sure the team is informed. I've built really good relationships with school nurses over the years that know my child, and I love them and I'm grateful for the support they provide. You mentioned IEPs. You know, many children with epilepsy in our country either have an individualized education program, an IEP, or a 504 plan. You know, both are documents that list accommodations and supports for kids in school. Depending on what they qualify for, you know, will determine which one, but my daughter has an IEP. And so while the focus on that is her educational services, I always make sure that it's noted in her IEP that she does have a seizure action plan and that it's kept together, you know, in her school documentation. Something else that I've been doing since developmental preschool is putting her seizure action plan in a red folder and having it in her backpack. And so it's with the school nurse, it's in the classroom, it's in her backpack. So when she's on the bus or whatever, you know, the school has that available to know what to do. And I will tell you, we have used that in emergency situations on the bus, but the aide was very grateful that in that red folder, she had instructions on how to respond to Brooke's epilepsy. And so just really having an open communication with the school team is what I would suggest for parents. And just, you know, it's a little scary. It's very scary, actually, sending a child who is nonverbal in my case to school. But thankfully, our school teams are ready and willing to learn how to address their seizures and to keep them safe so they can learn like their peers.
Well, thank you for sharing your experience and Brooke's experience. And it sounds like that red folder is a critical piece of your story and her care to have a successful back to school. So thank you for sharing that, you know, part of your story as well, because that is very, you know, important to find those pieces that can really be helpful. And, you know, something as simple as a bright red folder that someone might not think about that they can incorporate into their care plan. So thank you for sharing that with us. Yeah. And I want to move to Dr. Miller. So we've heard, you know, Dr. Williams and Brittany talk about seizure action plans, and my colleague put a link into the chat for everyone about seizure action plans. But can you tell us more in depth about what those are and how they can really assist individuals with epilepsy and why they're so important?
Yes, and first of all, thanks for having me and to the foundation for having this. This is a very important topic for anyone returning to school, whether that's elementary, middle school, high school, or college. Is another a whole other topic with transitions, and the importance of seizure action plans is still very much there. So I think the most important thing is what a seizure action plan does is that communication is key. All of the people who will be around your child or your young adult, depending on what age they are in school, might find themselves in a situation to assist or provide care or seizure first aid if your child were to have a seizure. So the seizure action plan is really something that gives everyone standardized communication and education about what to do for your particular child or adolescents in the event of a seizure. So it allows you to have sort of and I love the idea of a red folder. I know other parents have put it on teenagers on cell phones, whatever makes sense for your family and for your child. I think that what it can do is provide what your child needs in a very specific way to your child, but also some standard things like what to do in the event of a seizure. So most of the seizure action plans that you'll see via that link also include basic seizure first aid. And we want as many people as we can get across the nation to know what to do with in terms of seizure first aid. So that is there, but then it allows you to include information that is specific to what should be done for your child's case, so that 911 is not called when it doesn't need to be called. 911 is called when it does need to be called. So it really is a communication tool. And other panelists have said this, but the school nurses are so vital in this. There are some rural schools throughout the country that may not have a school nurse in them at all times. There are a lot of schools that share nurses. And so it's really important when you have a seizure action plan to speak with at the administration at the school of who should have this in the event that who is someone who can be here all the time when my student is here if the nurse isn't here to address this. So things that are included in a seizure action plan are what the child's seizures look like, what to do in terms of rescue medications, what to do in terms of seizure first aid, who to call, basically steps for each child in the event of a seizure. And parents and patients should put these together with the assistance of their physician. So just like I believe it was Brittany said, over the summer or early fall, having that meeting with the epileptologist, neurologist, whoever's providing the care for your child, and going over the seizure action plan, making sure things are up to date. If your child has changed medication, if something has happened developmentally, that you want to make sure that everything is the same. So it really keeps everyone on the same page, and sort of a guidebook for an educator, a nurse, a staff member in a school anyone who might encounter your child, to keep your child safe. So it's a communication tool that helps ensure safety.
Thank you, Dr. Miller, for that deep dive into seizure action plans. You covered one of the questions that actually came in from the audience, asking what are all the pieces of a seizure action plan? So thank you for answering that question. I want to move to Monique now. So navigating the transition to college can already be overwhelming with or without epilepsy. So can you share your experience living with epilepsy and navigating this transition?
Thank you for having me. So I was a non-traditional student, which meant I went back to college later in life. So I had a grip on epilepsy as an adult, but I didn't have it as a student before. I didn't have a 504 plan or IEP growing up, although I probably should have. Things are different back in the early 2090s. So navigating college and accommodations was a little different for me because you have to have reasonable accommodations in college. They don't really go with the 504 or IEP plan. You as an adult, so you're an adult now, even though you're 18, you might be a freshman or you might feel like you're still a kid, but you have to go to the doctor, go to the doctors, and they are the neurologists, and they will give your information, and then you take that to your disability service or accommodation services at your campus, and they will decide, what is a reasonable accommodation. It can't alter the course of your class. It can't go, you can't, basically cheat if you would like to. So some examples that I had going into college was like alternative testing. So I had like double time on my test, formula or word bank. I would get PowerPoints or notes ahead of class just to study. As you know, memory is a big thing with epilepsy, especially our medications. Oh my goodness. And then like flexible deadlines. If you do have a seizure, you might not be able to go to school the next day. And for me, I tell people all the time, I use this a lot because sometimes you're just tired. You may not have had a seizure, but you might have been tired the week. And so you might just need that day to just relax and then go back. And you meet with your accommodations counselor, you get it in writing, and then you set up a meeting with a professor and you can go over it. And they might say, cool. Some might say, okay, well, what time do you need this deadline? And you kind of make a date of when that deadline might be due. So I also disclosed, I was really comfortable with my friends on campus. So I told them like, hey, I have epilepsy. This is what you do in case of an emergency. I don't need the ambulance to be called. My husband is on speed dial #1. You can just click on my iPhone and he will get them a notification. I also had a seizure app on my phone so he could see it if something were to go wrong. And I also lived at home, so I did not have to worry about living on campus because I went home at the end of the day. So that's just kind of an idea of how it was living with epilepsy for me.
No, thank you for that feedback. I know I can relate to a lot of that being diagnosed in college and, navigating that and, living in a dorm and who to tell and disclose to and all of that. So thank you for sharing that experience because oftentimes I feel, you don't meet a lot of people in that age group to talk about that with. So thank you for sharing that valuable information. And I want to hop over to Dr. Williams again. So we've talked a lot about seizure action plans and everything, but we've touched upon seizure rescue therapies too. So I want to get back to discussing those a little bit since we often get questions about seizure rescue therapies. Can you define what those are for our audience and when they are used, since they're part of a seizure action plan?
Absolutely. You know, and again, it's so funny that over the course of my career, long as it's been, there's been an evolution. I remember when I was in training, rectal diazepam was just coming out. I mean, before that, there wasn't really anything commercial that you could use. Since that time, obviously, we have other versions of that. Obviously, in a hospital setting, we have access to intravenous formulations. Um, we also have nasal sprays that have been kind of created on the fly, but now we actually have commercial representations of nasal diazepam as well as nasal midazolam. I will say a lot of it kind of depends on where you are, your location, also your payer, because that, you know, it's something we don't often talk about, but is a real life issue. I mean, it's fine for a prescriber to write a prescription for medication, but if your payer doesn't pay for it or you have to pay for it out of pocket and it's quite expensive, um, you know, you may not be able to access that. The reason why I share all this is just to say that we really do have a variety of different options. Now, just to that point about cost, when I first arrived in Phoenix from elsewhere, I used to be a very big user of rectal diazepam, but one of the local payers just didn't pay for it, just would not pay for it. And so my local colleagues had really developed the use of oral disintegrating tablets of clonazepam, which is really an off-label use. So I want to be very clear, this is not an FDA-approved use, but that was really the local practice here. And so that's something that we actively use a lot here in this region. So an oral disintegrating tablet in a cheek, because we never put anything inside the mouth, inside the teeth during a seizure. But that's something that we use. It's been very effective. It's inexpensive. So even if you had to pay for it out of pocket, families still have been able to pay for it. And again, we flooded the area with it so much that I think our local school nurses have become very comfortable and used to that. So I think that's important. That those are some of the options. And I think as everyone's been kind of mentioning, a seizure action plan is really an individualized document. So it really needs to be individualized to your epilepsy and the details, the specifics of your particular epilepsy. The reason why I kind of add that is that for some people, I think if you look at a standard prolonged seizure protocol, usually in a hospital setting, it usually says at 5 minutes, you really need to start making proactive steps to stopping that seizure. I would say in my group, we kind of push that number a little bit lower, 3 minutes to 5 minutes for most of our patients. And some of the rationale for that is that you are not in a hospital setting. And so starting proactively to try and start a seizure gives you a little bit of lead time so that if it's ineffective, you're still not too far behind the 8 ball if you need to call in health professionals such as 911 or getting someone to a hospital setting. But again, talk to your provider because different providers have different views about that. I also have to say that for most of us, when we think about seizure action plans, we think about that prolonged continuous seizure. And again, 3, 5 minutes, whatever that time frame is, it's important to know. But I would also say that an equally important part of a seizure action plan for me is talking about repetitive seizures. So sometimes you don't have a continuous prolonged seizure. Sometimes you have repetitive seizures, and those can be disabling on their own, or sometimes they may be leading up to a more dramatic seizure. So I often encourage my families to use their rescue therapies, even if they're having repetitive seizures. Now, that's a little bit more challenging to give people criteria to use because different epilepsies, different patterns. But what I often end up telling my families is if you are asking yourself, should I be calling 911 or should I be going to the hospital? Then you should have already used your rescue therapy. So, like I said, it's a ongoing discussion, and I'll kind of leave it there.
No, I appreciate all of the details with that because, like you said, it's a very individual, unique journey. And we're gonna tap Dr. Miller here to add some more about rescue therapies. Because I know for me, I wasn't, given a rescue therapy when I was first diagnosed and all of that. It was coming out of an epilepsy monitoring unit. My husband was like, do we need something? She was just off all of her meds. Like, I feel like there should be some safety, like measure here that we have as she's like getting back on all her meds and everything. And that started our conversation. And when I was first prescribed rescue therapy, so I wanted to ask Dr. Miller, if someone doesn't have a seizure rescue therapy, do you have tips on how they can talk to their healthcare team about it? And also, is training available on how to deliver a rescue therapy? Dr. Williams was kind of, talking about the different types that are out there.
Yes, so I think if your child or you or your adult or anyone who has epilepsy it has active epilepsy and does have seizures, and they do not have a rescue medication, and no one's ever talked to you about a rescue medication, it is a time to advocate for that with your healthcare provider. And so sometimes, actually what we know from research is that people now are most likely to get their health information from others who have a similar experience. So instead of maybe calling the epileptologist or neurologist office, they might go on to an Epilepsy Foundation chat room or something like that. I don't think we have those anymore, but some sort of social media peer-based. And so they may hear that, oh, well, this person has a rescue medication. I've never heard of that. And so some of you who are on this webinar may have had that experience. So advocating for yourself and for your child with your provider is very important. And that can be intimidating to do. And so I think using the Epilepsy Foundation as a resource in terms of how to ask for that, what is a rescue medication? But the thing that I found most helpful with families is that if you're doing it in person, if you're doing an in-person visit, writing down the main points that you want to hit. Does my child qualify for a rescue medication? If not, why? Is there a reason? And also keep in mind that if your child, you really feel like this child needs a rescue medication, and I keep saying child, I mean anyone, but needs a rescue medication, and that is not, your provider is not agreeing with that, you can go to a different provider. And I'm not saying to just totally abandon your provider. That's not what I'm saying. Have that conversation first, but sometimes that is what is necessary if you are, especially what Dr. Williams said about the repetitive seizures, is sometimes we do just think about it in the prolonged, but the repetitive seizures also need to be treated with that. So I think having that information with you when you go to your provider, written down, here are the key points. Here's why I would like to maybe consider that. If the provider is saying, we don't think so, why, because there could also be a reason why, right? And then also most systems now use something like MyChart or some sort of online portal. So you can start the conversation that way. But really just saying, I would like to advocate for my child or my loved one, and I know about rescue therapies. Can we have that discussion? So really just having a list of, that could be one of several things that you want to talk about. You could also want to talk about comorbidities, anxiety, or things like that. But really, if you don't have that prescribed, I agree with you, Allison, like leaving an EMU, having been off all the medications and not having a rescue medication is very scary. So coming to webinars like this, being involved with the Epilepsy Foundation can help you know what to ask in terms of rescue medications. To answer your other question, there are different kinds of, that Dr. Williams talked about. Sometimes there's rectal, there's nasal, there's different kinds of things that we can give for rescue medications that we don't want to have oral if someone is having if someone is having a seizure. And there are trainings available through the Epilepsy Foundation and some of the pharmaceutical companies as well to help school personnel who may not have ever given those before. And again, a lot of school systems throughout the country have a nurse that travels around schools. So a nurse would know how to give those medications, but if he or she is not there, there needs to be someone who has had that training. And that's another part of advocating. I think at the beginning of this back to school time, when you're talking about rescue medications, who is the person who will be giving this if the nurse is not in the building, and how do we make sure that they're trained? And schools should have, one of the other hats I wear is I'm president of a public school board. So I deal a lot with public schools. And So schools should have, at least in Indiana, I don't want to speak for other states, but schools should have a special ed director and some sort of director of health. They're called different things, who are in charge of, if a student has a medical need, making sure people are trained. One of the questions that we got in the chat was, should I talk to cafeteria staff and bus drivers? Really, there should be an infrastructure that exists within the school to make sure all those people are trained and have what they need, so you're not going individually. So starting with the school nurse, and then maybe working with other school administrators, and they should be able to ensure, once they have that seizure action plan and the information about your child, that everyone who's going to interact with your child has the correct information, so that not only are we following the seizure action plan, but if we are giving medications, we are doing so safely and in a timely way.
So, Dr. Williams, did you have something to add to what Dr. Miller had? I see your hand up.
Yeah, I guess I feel pretty strongly about this topic. I don't feel like any person with epilepsy, certainly, and anyone who's had a seizure should have to go hat in hand to their provider. I think it comes across as very patriarchal for someone to say, no, you don't get this. We're talking about trying to reduce risk, and we know that prolonged seizures are dangerous, and certainly disabling. And I think this should be a standard part of any epilepsy treatment plan. So, if your provider has it, I think it's more of a gentle reminder and nudge. Oh, and by the way, what rescue medication are you going to prescribe me? Now, again, there can be some financial issues and what insurance covers, but I think that's something you need to talk about with your provider. But I feel very strongly you should not feel as a family member or as a person with epilepsy that you have to politely ask, oh, by the way, would you mind giving me that? I really think that should be an integral part of anyone's epilepsy treatment.
Thank you both for those comments, because I just know as a patient myself, advocating and all of that is, very important. But also sometimes just having the doctors bring up these conversations and not having to advocate for yourself, it's just a really, good thing that happens as well. But it's so important to, knowledge is power, being educated and knowing what to ask and things like that. So I see Dr. Miller's hands up, so we can go back to Dr.
Yes, I wanted to agree with Dr. Williams. It is not something that is an extra. Any care that you get, whether it's a referral to a mental health provider, it is not something that you have to earn or deserve or to earn or work for as a patient. You deserve it. It should be standard, and you do not have to feel bad about reminding or bringing up. But to Allison's point, the goal is that providers, and so there's some, education and intervention that needs to happen with providers, that providers would not rely on the patient to bring that up, but if you are in that situation, I think what Dr. Williams said is perfect. What is the rescue medication that you will be prescribing me or my child is a perfect way to address it. You're not asking for something extra. This is part of the basics.
Thank you both for that wonderful response. And my colleague has put some great links in the chat around rescue therapies and, managing conversations with your healthcare team, to just add to what Dr. Williams and Dr. Miller were sharing with us. And I want to jump to Brittany to talk kind of through some of the stuff we've heard about, Dr. Williams and Dr. Miller talking about. How have you incorporated seizure rescue therapies into Brooke's seizure action plan, and who is all trained to administer the therapy? We heard, Dr. Miller talking about, the training and how it is in Indiana. So just curious, how have you worked to have different people trained, so that Brooke is safe with back to school?
Sure, thank you. So thankfully, our epileptologist has always made sure that Brooke has had rescue meds that she's needed since the beginning. And so which one we used has evolved depending on her seizures and how they're doing. But currently we use a nasal rescue med, and it is crucial for her to have noted in her seizure action plan, when to give it, how long to let the seizure, quote unquote, go before administering it, what the name of the medication is called. I also make sure to inform her team in her seizure action plan what some of her triggers are, because she's pretty sensitive to noise or stress. And often when those happen at school or even at home, we kind of know, going to be a bad one. She's going to need rescue meds. So just educating her team on her unique epilepsy experience is really important. And then also on the flip side, the post-ictal phase, afterwards, what you can do to comfort her after she's having a seizure, noting, with her epileptologist, of course, when to call 911. But for us, rescue meds have been part of our journey, and it's been, almost 15 years. Certainly for parents, making sure you're confident in giving it. It kind of sounds scary, rescue medication, but I think of it as a tool to hopefully keep us out of the hospital when you have a child who's a frequent flyer. Of course, we're grateful for our children's hospitals, but it's stressful. And so if we have a tool in a form of a rescue med to be able to keep her home, while safe though, for those prolonged seizures, it's really important. And so I've always, worked with her school teams, gone in, of course, like Dr. Miller and Dr. Williams mentioned, our school nurses are trained, but being the advocate mom I am, I still go in, show the school along with the nurse, staff that are in her classroom, the aide, the teacher, her one-on-one, making sure they're comfortable when to give it and how to give it. So that way she can participate in life, go to school, ride the bus, be on field trips, because inclusion is so important, and something we have to fight for sometimes as parents of children with epilepsy and other disabilities. And so just having clear, documentation in that seizure action plan of which, when to give the rescue med, what signs to look for, timing the seizure. In our case, depending on the seizure type, sometimes we have to give the rescue med immediately because we know it's going to be a significantly prolonged one. And so just like I mentioned before, just being in clear communication with your child's school team is really important, so everyone feels confident in supporting them at school.
Thank you. And Monique, we got a specific question for you, so I'm going to jump to that question. One of our participants or attendees is asking, as you shared, as you started to tell friends and classmates that you have epilepsy, what were some of the most reoccurring questions that they had?
Let's see. What do we do? If you have one, what do they look like? I actually, before I transferred to the college that I graduated from, I actually had a absent seizure in class, and a girl noticed it because the TA was helping me with a math problem, and I kind of just like went off, and then she noticed it, and so from then on, she sat next to me just so that she could be there to make sure that I was good, which I thought was really nice of her, and we became really good friends. We're still friends to this day. So, they were very compassionate. I had another incident happen at school where she was actually a friend of mine, saw me I was experiencing an aura, and she was able to kind of calm me down and get my husband on the phone. So they were really supportive as far as that, really just being transparent as you want to be. You don't have to if you're not comfortable. But I was a neuro student. A lot of people in my class were neuro majors. They're going into this field, so they actually thought it was kind of a cool thing just to kind of experiment on me, I guess. um but just to get that knowledge and that information. And so but really they just wanted to know what to do. How can I help? If you're not in class, can I help you? And I think the other things were just, can you drink? We're college students. And that's everybody's personal choice. That's everybody's personal individual plan. So just, regular things like, what can you do? What can't you do? Things like that. Yeah.
Thank you for that response, Monique. I can relate to so much from what you shared. Since as I shared, I was diagnosed in college, my triggers being lack of sleep and stress, which are really, hard to manage and navigate in college. So I love that you were met with just as much kindness and compassion from your new friends as I was. I love hearing that. We have another question from the audience I'd love to ask anyone on the panel, so please feel free to chime in. They're asking, is it important to discuss epilepsy with the student's class as a whole, as long as it's age appropriate? So whoever would like to go first can please chime in.
I would say, especially for little kids, they're a lot more resilient than you think. I have an 8-year-old. And she knows what to do with if mommy has a seizure. And just was asking, I mean, the first thing she asked when she was, I think, 3 or 4 was, why doesn't mommy drive? And so we had to have that conversation very early on. And so I think she really understood, and even my niece understands. So I think if that might be something as a classroom, just a lesson for the little kids, to understand that this person might be different, like different types of disabilities. This is one that definitely could be incorporated with the school system. And I think that goes along with the seizure safety, aid teachings and things like that. And then also, like I said, with older people, if you don't have to disclose that information if you don't feel comfortable. But I do know kids are a lot more compassionate, and they're actually funny when it comes to I think they're curious to know, especially if they have a friend who does have epilepsy. Actually, as a matter of fact, my daughter does have a friend who has epilepsy, and she was like, "Oh, Zoe, she has epilepsy like mommy." So she totally made the clear the correlation between the two.
Thank you. And then I see Brittany, you have your hand up.
Sure. I just was going to share, I've had this experience before where at the beginning of the school year, making sure my daughter was comfortable with it, but talking with her classmates and even the kids that her age, not necessarily in her classroom, because she spends part of her day in the special ed classroom. Something that's important to me is obviously talking about the fact that she has seizures, but making it very clear that this isn't who she is. She's an amazing little girl who has these likes and interests, and her epilepsy doesn't define her. It's just a part of her life. Early on in our journey, Child Life, they're so wonderful at our children's hospitals. They talked to her sisters, who at the time when she was diagnosed, they were young, and they were trying to explain, what epilepsy was, and pretty well, they described it as like a thunderstorm or electrical storm in your brain. And so her siblings thought that was super cool. And I remember, anytime I've shared that in the classroom, most of the kids are like, oh my gosh, that's so awesome. you know, but I think it's important, but really making sure that it's emphasized that epilepsy is not who they are. They're a child in school like you guys, and they want to have fun, and these are their likes and dislikes, but they happen to have this diagnosis. And children are resilient, like Monique said too. They're pretty accepting. Unfortunately, I think it's the adults sometimes that we have to work on. But in our experience, it's been really helpful to do that.
Thank you both for that. And Dr. Williams, I'll have you respond as well.
Yeah, and I think just to echo what others have said, I think disclosure is a nuanced issue, and really kind of depends on the age of the patient, the type of seizures they have, how frequently they have it. If a child only has seizures from sleep, that may not be something necessarily want to bring up with the classroom. But at the same time, if a child has a seizure in the middle of the classroom, it's the elephant in the room that you have to discuss. So I think every family has to come to that differently. And I think, just like some have said, I think young children tend to accept it much more easily and kind of just walk away and move on with their lives. Older children may develop a lot of self-esteem issues around that. So I think having a discussion with the family, the school, and kind of thinking about the developmental context would be helpful.
Thank you. And last but not least, Dr. Miller.
Yes, most of what I'm going to say is just going to be the same as the other panelists, but the disclosure is a very, very deeply personal experience for any chronic condition that you have, and epilepsy is it's better than it was when I was diagnosed a long time ago, but it's still stigmatized, and so I think we want to be very mindful of the stigma while also trying to talk about epilepsy in a way to destigmatize it, right? That's part of the destigmatization process, is to talk about it factually and objectively. And so I do think it's a very personal thing. And I'm thinking about older students who are in high school and in college. I've done a lot of work with people who are in that transition period from high school to college or high school to the workforce, and really coming up with an individualized plan for, am I willing to disclose? Because that's the first question. And I don't think anyone should be forced to disclose anything about their health. But then who does need to know, right? So just like Dr. Williams said, if these are nocturnal nighttime seizures, may not need to. But there are other times when it is a safety issue. So what I would say is I think it's a very delicate thing. It's very important, but it needs to be done very mindfully. And whoever's doing it, I'm thinking of an older child or teenager, that they have a lot of support in doing it if they or their family does determine, okay, we need to do this. It just needs to be done very mindfully.
And I just want to dovetail. There's one instance where I do really push on my patients to disclose, and that's for my patients who are going off to college with their roommate, because I don't think it's fair to their roommate to wake up in the middle of the night to a seizure. And I think it's potentially dangerous to my patient if someone doesn't know what to do in that instance. So that's the one where I do say, I think, it's in all fairness, you probably need to disclose that, your rescue plan, your rescue medication, where to find it, who your contacts are. But I agree with everything everyone else has already said.
No, thank you for all of those perspectives. I know I can relate to all of those, when I was first diagnosed, not wanting to talk about my epilepsy, but then realizing, how important disclosure is. I found it made me safer in workplaces and college, like Dr. Williams was just saying, and, different things like that. So thank you for sharing all of those perspectives. And we only have time for a few more questions. I feel like we could talk for another hour on this topic. But I do want to touch on one thing before, I turn it over to everyone for any last thoughts or tips. Dr. Williams, I know we were talking when we were talking about rescue therapies about, those seizures that, can cluster, just kind of keep going. And I think I know what your answer might be, but what should someone do if a rescue therapy doesn't work to stop their seizures? How should they handle that?
Well, I think in the moment, and this really should be part of the seizure action plan, I think we've touched on this, we have to understand that seizure rescue medications may not work. So when do you call for help? For some people, it may be the onset. For me, it may be I give your medicine a few minutes to work. If it's still not working, you need to call 911. But I always say as a caveat, you call anytime you're concerned. That's always the default. If there's any concern, even if you happen to use your rescue, call 911. If they don't need to transport, they won't. But I'd rather they be there and not be needed than for them to be needed and not be there. So I think that's in the moment. I think the other issue though is what happens if you used it, it didn't work, and situation has resolved. I think that's one of the times where you do need to reach out to your provider between visits and say, hey, I had a seizure action plan and it didn't work, because there are lots of different options at that point. Maybe the dose of the rescue needs to be increased. Maybe we need to transition to a different rescue therapy. Or sometimes for some of my patients who I know have prolonged seizures, I don't wait 3 minutes. As Brittany's alluded, sometimes I say, you need to give that at onset. Because one thing we do know, the longer seizures go on, sometimes the more difficult they are to stop. So time can sometimes be an important factor as to whether or not a seizure action plan works. So again, seizure action plans are individualized, so that needs to be a discussion with your provider. But again, if it hasn't worked, I think that's definitely a reason to contact your provider just to make sure that it was applied correctly. And if it was and it still was ineffective, then I think we need to think about how do we change the seizure action plan.
Awesome. Well, thank you for that answer. And I want to just let everyone, as we wrap up here, have, a little bit of time. We've learned a lot about seizure action plans, seizure therapies, disclosure, lots of wonderful information. So any final thoughts or helpful tips you'd like to share with our listeners? And we can just popcorn around the panel and maybe start with Brittany and, go around the panel.
Sure, thank you. As you prepare for back to school, I know in Arizona, our kids have actually been in school for a few weeks now. Communicate with your child's team. I know that there have been questions about, services or potential schools they could go to. Definitely, special education advocacy could be its own webinar. But if you need support, reach out to your local Epilepsy Foundation office. I can even put my email in the chat for parents that need some guidance on school issues and making sure your child with epilepsy has the services and support they need. But definitely, I'm happy to help, and I'll put my info in the chat.
Awesome. Well, thank you. We appreciate that. And let's go to Dr. Williams.
I'm a big believer in that old NBC slogan, knowledge is power. So I think the more you can get informed about your child's epilepsy, I think as someone alluded to, their triggers. Now, not everyone shares the same triggers, but learning to identify what your triggers are. Big ones include lack of sleep, missing dose of medication, stress. Learning how to deal with those goes a long way to giving you power and control over your epilepsy.
Thank you. And let's go to Monique.
Yeah, I think really just being responsible. We're now, if you're a college student, you're now an adult, so you have to kind of take responsibility for your health. Another thing I was going to say is, set a timer for your medication, because you might have different class schedules now. It's not, like elementary where you have lunch at a certain time, you have different classes. If you know that you are tired in the morning, you might want to have afternoon classes. If you know you're a night hawk, you might, keep that same energy. If you want to have morning classes, so you have the night to yourself. So those are just kind of some key ideas for college, for classes and things like that. And I could put my information in the chat as well.
Thank you. I appreciate that. And those are definitely great tips. I know I use some of those when scheduling classes back in the day. And then we'll go to Dr. Miller to wrap us up with tips.
Yeah. So I think everyone's hit on some really good things. I think I would just reiterate that if you're struggling, you don't know what to do, or you have questions, reach out to your provider, reach out to the Epilepsy Foundation. There's the helpline. I think just making sure that, I mean, back to school is busy even without epilepsy. And so you add the complexity of having a child, or you yourself have a chronic condition. You don't have to go it alone. I think, like Dr. Williams said, anytime you have a concern is when you can call your provider. You don't have to ask permission. That is their job. Like I tell my daughter, who doesn't have epilepsy, but doesn't always like to interact with the healthcare system because she gets nervous, I say, that's literally their job. That's what they expect you to do, is to come to them with concerns. So that's the job of your provider. That's the mission of the Epilepsy Foundation. So just don't go it alone. Reach out for support.
Send that my chart message. Yeah, I love that. So I just want to say, thank you so much for joining this discussion and for your support of the Epilepsy Foundation's mission. A special thank you to Drs. Miller and Williams and Monique and Brittany for joining us and sharing their expertise and, personal experience with us. If you hang on, I'm going to share a couple of resources. Dr. Miller already talked about one of them without knowing I would be sharing about it. But a big thank you again to our sponsor, Neurelis, who sponsored this back to school webinar for back to school month. We covered a lot of important topics: seizure rescue therapy, seizure action planning, and covered a lot of great essential knowledge and providing guidance to parents, friends, and educators on these topics. We've recorded the webinar and we'll post it on our YouTube page very soon. And you can also find other videos on many other topics as well. I know my colleague has been posting a few of those in the chat. We did a webinar on navigating the transition to college. So that is also on our YouTube page. And then we have a few resources here I wanted to share. We want your feedback. Your feedback is so important to us. It helps us create these webinars, know what topics to talk about. We really, when we hear from you, it helps us build out the webinars. We want to share educational material that is important to you. So if you take a few minutes to just fill out that quick survey, there's the link, and I know it's been put in the chat, I think, a few times. So we would love to hear from you after you attended today. Dr. Miller mentioned our helpline. Thank you for plugging that. But if you have any questions ever, if you have any questions after today's webinar, maybe in an hour, you're like, oh, I wish I would have asked this, you can reach us. So give us a call. We're available 24 hours a day, 7 days a week on our helpline, and you can see all the different topics that we cover. And the numbers are on the slide there, and we're available in multiple languages. And you can also email us if you'd rather email us, and we'll get back to you. And that's contact@efa.org. And then also we have support groups because we know epilepsy is a journey. and oftentimes support is really important. So we offer a variety of support groups for members of our community to connect and get support from one another. We also offer bereavement support groups for those who have lost loved ones due to epilepsy. So to learn more and to find one in your area, or we also offer many virtual support groups. You can visit that link there to get connected to a support group. And lastly, thank you. Thank you for joining us. Thank you again to all of our fabulous panelists that were here today. And thank you again to our sponsor, Neurelis. And we hope you all have a wonderful day. And if you have any follow-up questions, please let us know. Please give us your feedback. And we hope to see you on a future webinar. So thank you so much, everyone, and have a great day.